So actually, menstruation is also one of the symptoms of these hormones, right? So menstruation is just a symptom in itself. And because of these hormones, there are other symptoms as well, like, as we said, the mood disorder, the pimples, the acne, the lower abdominal pain. So it means that we really need to understand how these hormones affect our body, right? So going back to again the way the effect of the hormone is, the estrogen is more affecting our vessels, more affecting our bones in a positive way and in a negative way as well. And progesterone is actually a depressing hormone. I don't know whether you know if it is written in the books, but it is actually a depressing hormone. However, estrogen is kind of euphoric hormone. So these definitely have the effect on the moods as well. So when we say about the primary dysmenorrhea, that because it is effect of the hormones, then it starts immediately with the withdrawal of the hormones. So it's when the prostaglandins of the uterine muscles are being released, they cause crampy movement and crampy contractions of the uterus, which causes these pains. So that is where you get the pelvic pain or crampy lower abdominal pain. And as the bleeding settles, the prostaglandin level go down, the pain automatically settles down. And that's why, because the cause is the prostaglandin here, when we advise the girls to take antiprostaglandins like Brufen, simple over-the-counter medicine, they get relieved. So the key of the treatment of primary dysmenorrhea is in fact to take the tablets before the prostaglandins are being released or they are getting into a level where they cause symptoms into your body. So ideally, if these medications are prescribed for primary dysmenorrhea, we should ask the girls that the first symptom of dysmenorrhea, or if your cycles are very regular, then you better start a couple of days before the period come your tablets, and then your period you will be pain-free. And it really works. It definitely works. One second. How to, yeah, that's fine. Yeah, I'm okay. So when we talk about the secondary dysmenorrhea, the secondary dysmenorrhea has a different etiology. That's why it's still the prostaglandins are the things to be blamed for the pain and for the for crampy contractions of the uterus for this pain. However, this pain is very deep. When we are examining of the patients for secondary dysmenorrhea, we also say that they had very deep pains for this, because etiology is a little bit different. So secondary dysmenorrhea is more due to the kind of endometriosis. So do we know what is endometriosis here? Can I get some of the interaction from any of you, at least those who are on the screen?
Yes. So endometriosis, I guess we got taught in 4th year. So I wouldn't expect anyone younger than 4th year to know this, but it's when we have ectopian uterine tissue anywhere else in the body.
Yes. Hamza, can I ask you what is the Arabic of the endometriosis? Because I learned it. What is the Arabic name of endometriosis? No, 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 no. I tell you, it's exactly rightly said that this is the ectopic presence. So in Arabic, it is called batana muhajira. And I liked it because muhajira means something which is migrated. So it means that endometriosis is not really it's the endometriosis which is present in an abnormal place. So it is migrated from lining of the womb, from inside the womb to other places. So that is very actually by itself, what you say, that it describes itself. So dysmenorrhea is most likely due to the endometriosis or due to the fibroids or due to the adenomyosis. So adenomyosis is also, again, it is the presence of the endometrium still inside the uterus, but it is inside the muscles of the uterus, right? And the pelvic inflammatory disease is the infection of the urinary tract, tubo-ovarian masses. So, yes. Again, if you understand what is the cause, then you can easily treat. So treat the cause, you are going to treat the symptom. So basically, primary dysmenorrhea, secondary dysmenorrhea, they are just the symptoms. They are not really the diagnosis here. So once if you know what is the cause, and then it is easy for you to treat it. Mm-hmm. Now, before I jump on the treatment, if anybody has any question, ask me.
Okay, so from the questions, we have a question that how does one differentiate, like a lot of people suffer from painful periods. So how would one know if it's normal painful period or if it falls into the category of dysmenorrhea?
Yes, good question. So as we said, that primary dysmenorrhea starts with the onset of the period. So it means that it starts just when the period starts, right? And it weans off as the periods settle down, because normally most of the patients, if you ask them, they say that, yes, I get very, very strong pain when my period starts. And when the blood gets its flow, then the bleeding is settling and my pain is going away, right? So it means that this is primary dysmenorrhea. Even if you don't take any painkiller, primary dysmenorrhea is self-remittent. It will go by itself, right? Secondly, primary dysmenorrhea goes away normally with giving birth and childbearing. And again, we don't know what is the cause, but then it comes back after in the age of 40s again under the umbrella of the premenstrual syndrome. However, the secondary dysmenorrhea is getting worsens instead of improving on the third and fourth day, right? So this is one of the difference. And second thing is that it's very, like deep pain, congestive pain, that is like the difference is inside the symptomatic difference, right? As you asked that how would one know? So it's just difference in the symptoms.
Yeah. Okay. Thank you.
But the differentiation will be by you can further diagnose it by nowadays, ultrasound scan is such a excellent modality. And it's not really expensive, because once if somebody has spent on the machine, then the rest of the scans are free for life. So ultrasound, if you use it in primary dysmenorrhea, the ultrasound scan will be absolutely normal. But in secondary dysmenorrhea, on ultrasound scan, you can easily diagnose adenomyosis, you can diagnose endometriosis if there is collection of some blood somewhere, like a small chocolate cyst. And so it can be differentiated on the scan as well, right? However, you cannot differentiate from the hormones that I say that progesterone will be like this or estrogen will be like this. No, nothing. There's no blood investigation which can investigate or differentiate between these two.
Okay. Okay. We actually have we asked people to submit myths about their menstrual cycle before they registered for this. So can I have Fatma read out a myth related to dysmenorrhea?
A common question, or myth to be specific, was that painful periods are completely normal and happen to every woman.
Not really. But this is what we do tell the patients. It is very common, but it doesn't really happen to everyone, because it is, again, it's very much depends on the lifestyle and on the positive attitude of the women and the girl and life. I mean, actually, it runs in the family. Like I have seen mother, grandmother, and all the sisters, and everybody's having, period pain, and there are families who don't care, don't bother. So I think this is more about the lifestyle, and the positive attitude towards life is also one of the factors. But we can definitely say that it is very common. So there's nothing to worry about if someone is having pain and the other one is not having pain. Um, I mean, if you are not really missing from your day-to-day life activity, then it is normal pain. However, if you start missing schools, missing colleges, and then this become abnormal, because what I have seen, the symptom is dysmenorrhea, but actually, if you go into the detail, these kind of the patients are having, in fact, very heavy periods as well, and the pain is coming when they are really passing clots and they cannot bear with it, and they feel weak when the period comes because they might be easily losing, blood there. Maybe 200 to 300 mil of blood loss monthly is a great loss, because in a normal average monthly blood loss should be maximum 80 mil in a menstrual cycle, which a woman can easily handle, a healthy woman can handle. However, if this is more blood, they may not, everybody may not understand that what is heavy and what is light, because they might be having heavier bleeding throughout since they started the menarche. So it should be discussed and explored. There's no harm in doing that, instead of just saying that it's absolutely normal and no need to understand or no need to go and seek for help. There's no shame in seeking for help, but the doctor should also know when to interfere and when not to interfere. Next myth.
Next myth. Okay, so the next myth we have CMAB. CMAB, can you unmute yourself and say your myth, please?
Yes. Swimming or bathing in menstruation can cause diseases.
No. We said that it's very physiological. So it can only cause endometriosis or chocolate cyst if it is really causing a disease. Otherwise, it's a very physiological thing to have menstruation, and it should not really stop a woman or to make a woman sick. Like if you go into the history, you would find that, I don't know exactly, first century or second century, I mean, that kind of the ancient thing, the people were getting the girls or the women locked into the room, that you are not a normal person and you are not allowed to do this activity. And it's not actually even, in our religion, but people do say that, oh, in Islam, when the menstruation comes, women are not allowed to do certain things. So that is very partialism. No, in fact, in the ancient history, if you look back, they were considered as, like a chhoot or something like that, that non-touchable, something very, very dirty, which the culture has been changed. So it's a normal thing. It's not a disease. It's a physiological thing.
Okay. We'd like to, I think, move on now.
For the treatment.
For the treatment.
Yeah, as I said, that as long as the period pain is not really stopping you to do your day-to-day activity, then it means that it is normal and you are taking it as normal, and it should not, it does not need any treatment, right? However, if there is pain, or if there is even a little heavier period, we said in the beginning that prostaglandins are the cause of the pain. So if we give antiprostaglandins, which is non-steroid anti-inflammatory drugs like Brufen, which is available over the counter, or diclofenac, or mefenamic acid has been very popular for this. Why? Because mefenamic acid was actually one of the NSAID which was studied for this purpose on the large population. So that's how mefenamic acid got its more popularity. Secondly, it has some effect on, some X-chain, Y-chain, cyclooxygenase from this point. So how mefenamic acid has been considered a bit superior to other NSAIDs for the treatment of dysmenorrhea and heavy periods together, right?
Mm-hmm.
So For primary dysmenorrhea, it is the treatment of the choice for the first 24 to 48 hours, and that is it. However, when we talk about the secondary dysmenorrhea, then it means that treat the cause. Treating symptom is the same, that you give the woman all these medications like NSAID. If they are anemic, you correct the anemia. And then you treat the cause, the root cause. So the root cause can be a fibroid, which gets worsens when the period comes. So it means that you remove the fibroid, which is called myomectomy. I'm not talking about removing the uterus. It just means removing the fibroid. And removing the fibroid is also that whenever the fibroid starts giving symptoms, then it should be removed. Otherwise, fibroids are also very benign kind of the things. They are very innocent. They don't really cause any problem. Yeah. So they are just the thickening of the uterine muscle fiber. So if it is endometriosis, then endometriosis is again, if there is a chocolate cyst, you can clean it, remove it. But again, because they are young girls normally, so you don't jump on doing a catastrophic surgery or removal of ovarian organs or genital organs or uterus. Adenomyosis is very challenging because it is small. Can you listen? Yeah. Can you hear? Yeah. These are small vacuoles which are coming inside the myometrium. And it is even visible on the scan as well. So ideally, if it is happening adenomyosis and period pain in a woman of age above 45, I normally advise them that get your womb out and get your quality of life back, because that is the really gold standard treatment. However, in young girls, although it doesn't happen in young girls, but in young girls, if it happens, we have the medical treatment. And the medical treatment, remember I told you that progesterone and estrogen have different effects. So estrogen is actually, both of them relax the uterus. That's why in the pregnancy, they are coming in tons and tons and they keep the uterus too much relaxed. However, progestogen has more relaxing effect on the uterus, and progestogen also in different amount, different doses, it affects differently. So if we give progesterone, now this is very interesting, if we give progesterone in a micro dose on a daily basis, can you hear me?
Yes.
Okay. Yes. So thank you. So if progesterone is being given in a micro dose on a daily basis, it will start thinning up of the endometrium wherever it is. You get it?
Okay. Yeah.
That is really a very magical finding, because when you start constant dose of the progesterone, then it will start thinning of the endometrium wherever it is. Now, this gives you the clue, this statement gives you the treatment for heavy periods, because the thickened endometrium of normally located inside the uterus will become very thin. So the girls who are having heavy periods will start getting very light periods. So one thing. Secondly, suppose if a girl is having a chocolate cyst or endometrium in the ovary, that endometrium will also start vanishing up, and that endometrium will also become very thin. So the pain of the endometriosis will also minimum. So we have tried different kinds of the progesterone for this, but one of them is Dymagest. And it's like 2 milligram tablet every day for continuously 2 years, 3 years. Doesn't harm at all. The minute you stop, you come back to normal. And the same principle is actually for the, as I tell you always, that obstetrics, if you think about the age women group, then it's very easy to treat. So in adolescent group, when the girls are unmarried, they want to preserve their fertility and there's no problem, you can just give them Dymagest, 1 tablet a day, couple of years, and their symptoms will go. However, if they are at the fertility age group and they don't have plan for getting pregnant, then you give them Mirena Coil. So what is Mirena Coil? Mirena Coil is actually an IUCD, intrauterine contraceptive device, which has progesterone on it. So it's a depot kind of the progesterone, which is being released every day in a micro amount inside the uterus, because it is the device is inserted inside the uterus. So it releases a progesterone where it is needed the most. So it makes the lining of the womb very thin, and that is the magic. So the periods become very light, and then they may even stop, which is actually the aim of the treatment, and so there is no pain then. And if a woman is in a fertility age group where she wants to become pregnant, then you just surgically treat endometriosis and let them become pregnant. Because when they get due to the pregnancy, tons of estrogen, progesterone, it cures endometrium as well, right? And in a menopausal woman or any woman, perimenopausal, you got it? I'm telling you, adolescent. I'm telling you, fertility age group who wants to become pregnant. I'm telling you, fertility age group who don't want to become pregnant. Then I'm telling you, perimenopausal. So perimenopausal, if they have endometriosis, what we said we will do, adenomyosis, endometriosis, we'll just clean up the whole lot. We'll give them quality of life by surgical treatment and remove their wombs and remove their ovaries even, because they are going to go to menopause anyway. The post-menopausal are kind of lucky one, or you can say that they have already suffered a lot. So as soon they get menopause, their symptoms are gone away. Endometriosis doesn't say them anything because their estrogen, progesterone is already gone to zero. So they are fine then. So this is mainly the disease of the people who are having estrogen, progesterone. So it's actually very simple, isn't it? It's not that difficult. But if you ask me that what are the worst case scenarios I have seen in dysmenorrhea and endometriosis, I can give you some.
Sure.
Yeah. So you see, sometimes endometriosis can be very painful, and sometimes it can be not painful at all. I got a girl. She was beautiful girl. I think 24-year-old, came with the complaint of hematuria. Hematuria, we thought all investigations. I was that time in Drogheda in Ireland. So I was just, like getting urine cultures and antibiotics and all that. And then we did scan and we found that she have chocolate cysts. So we decided to scope her. And when we scoped her, we were astonished that she had such a bad endometriosis. The whole pelvis was full of chocolate, and she did not have that symptom at all. That was very, very strange,
Yeah.
And then adenomyosis, I actually perform. If I do, like I say 50% of my hysterectomies are due to adenomyosis, 50% are due to the multiple fibroids. I don't deal with the cancer. So because if I find cancer, I refer it to my gynae oncologist. So these are the two really major causes of hysterectomies, fibroids and adenomyosis for the women.
Okay. Thank you, Dr. Farah. We do have some questions piled up a little bit about dysmenorrhea and endometriosis. So I'm going to hand over the floor to Fatma Khan, and she will voice the questions, please.
Yes, people have been. Yeah. One of the questions is that does dysmenorrhea have anything to do with anxiety?
Anxiety is again too much with the lifestyle. These are the type of the people who get very anxious. If you start taking everything very lightly, then I don't think that this is really the cause of this. But what I can definitely tell you that I have treated the women with premenstrual syndrome and dysmenorrhea finally with antidepressants, and I got an answer. So because if you look at the anxiety and the depression kind of, these are also not really what I'm saying, that these are not really controlled by one's own mind setup. You understand? It's also the symptom of the chemical reactions which are taking place into your body, right? So this is how maybe they are interrelated, because there's something which is causing some chemicals which are causing these pains and premenstrual syndrome. So maybe the same hormones or chemicals are causing the depression and anxiety. So they might be related to each other in that way. So if you want to give anxiolytics to a patient who is also having dysmenorrhea, go for it.
Okay.
All right, thank you. Another question that was asked is that after menopause, if bleeding does not stop, then a girl takes medication for stopping the bleeding. Will there be any such consequences in that situation?
Menopause.
Yes. The
We'll
woman has
discuss it.
already.
Yes, we'll discuss it when it comes to the
Right.
menopause, because this is not at all what I am going to tell to do, okay? Menopause should be taken very, post-menopausal bleeding should be taken into, very, very seriously.
Right.
Yes.
Another dysmenorrhea question that was asked is a clarification question, actually. So if dysmenorrhea is primary, antiprostaglandin medications are the solution. And if it's secondary and due to endometriosis, prostaglandins are given. And why are we given antiprostaglandins in one case while prostaglandins in the other case?
No, in both, in both cases, it is antiprostaglandins actually, in both cases. What I was telling, that if it is secondary dysmenorrhea, it should be investigated. Even if it is primary dysmenorrhea, there's no harm in getting and seeing your doctor, and checking out that everything is fine. So there's no harm in doing it.
Right, thank you. And I'm just going to add a myth here that was commonly asked as well. As we heard, don't take showers during periods and don't drink cold water. Is that true or false? We have been told by our elders.
I tell you something. When I went to Ireland, we always used to give hot compression, isn't it? We still do hot compression. But when I went to Ireland, it was so cold, and I fell down and I got a sprain, and I was shivering with the cold, and immediately the nurse brought the ice pack for my foot, and I said, "Oh my God, you're going to burn me." So no, just try it, and it really ease off the pain, because cold compression is actually very good for for the pain relief. So basically, the both can be tried. Hot compression, cold compression. It has no relationship really. And taking shower is a healthy habit. I don't think it should be stopped at all because somebody is having periods. This is just really a myth. All what you can do is that get a right, like warm water for shower, and they will definitely feel better. Just keep telling your patients that it will not stop periods.
Thank you so much. Just the last one is that someone having primary dysmenorrhea with irregular periods, can they take ibuprofen?
Yeah, when irregular periods come, as I told you that, then I told those girls that just when you get a very first symptom of getting period, or you see a first drop of the blood, you should start taking the brufen tablets or mefenamic acid, constant tablets. Because if I tell you don't have like on the clock, the right time, that I will say that start 24 hours prior to the periods, right? So it just varies from person to person, and there's no harm. I mean, there's no abnormality in it. Everybody has their own body, and they have their own time, and they have their own body clock. You get it? So the normal period does not mean that it should be coming 30 days cycle. Like if you say that someone is getting a period every second day of the month, like 2nd January, 2nd February, 2nd March, then it does not mean that they have very regular periods. It means that still have kind of irregular period, because the some months are 30, some are 31, some are 28. So it just just go with the flow. Take it easy.
Okay, thank you, Dr. Farhan. Thank you, Fatma, for those questions. That was really interesting. I think now we're ready to move on to menopause.
Yes, that
A
is my
topic which
favorite.
concerns, I think, all
Favorite
mothers.
topic. Now, not only for the mothers, for most of the professors at this age. And then, how many of you believe that male menopause exists as well? Because I'm going to create this chapter in women's health, male menopause. You know, if there are female consultants, all of the students say, oh, these perimenopausal female consultants. But how many of you have seen the male consultants who are more cranky and more agitated than your female consultants? Huh? Tell me. Raise your hands. Hamza, raise your hand. Okay, just give me 1 second to change the slides.
Someone's clapping.
Escape. This is menopause. Now, did you get menopause slide?
Yes.
Okay. I cannot read the slides. These are for you, all of you to read later, okay?
Okay. You can open the first slide if you want that has a summary kind of menopause.
Okay. Yeah. Okay. So we said that menopause is a certain recognized, very respectable age group of the women, and it is an important part of the woman's life where a woman should feel proud of being herself and not being ashamed of being this thing, right? So what we say, gray is gorgeous, isn't it? Yeah, do you agree? Gray is gorgeous?
Yes.
Yes.
Gray, gorgeous. Old
Yes.
is gold.
Yes, yes. So
Agreed.
again, as the name says, menopause, which means that there is a pause in the menstruation, right? So it's again a symptom, it's not a diagnosis. So how does we say that, or a patient comes and tells me that I'm having menopause, and I say, no, you are not having menopause. It's like a kind of debatable. It's not a diagnosis because it's a symptom. So again, there is an age range where gradually the periods become a bit irregular and then they stop. And why does it happen? Because the nature exists, you know. I tell you the story of the ovary or story of the ovum. You know, when the life cycle starts of a female from a fetus, right? In a lifetime, when a person or a baby girl is 20 weeks fetus, then there are millions of uh, ovum follicles inside those ovaries, right? From the nature. Now, gradually, the atresia happens as a part of the natural course, and by the birth, millions are gone and hundreds are left, right? And then from birth to menarche, as if this is kind of the, you know, little bit of the time which is like frozen time, that it doesn't really decrease rapidly. But again, from menarche, the number of the follicles are much less than what they were at 20 weeks gestation and what they were at birth, right? In a woman's lifetime, suppose if a girl starts her menarche at 12 or 14 and then get a menopause kind of age of 50, then in a lifetime, if a woman does not get a pregnant and get a period every month, then by books we say that one follicle is being used in every month. Although all of us now, we are doctors and we know that there are so many times that there are anovulatory cycles, right? But still we can calculate, those who are very good statisticians among us would say that a woman uses 500 ovum in her lifetime of fertility or menstruating age group, right? So started with a million and used up only 500. So there's a continuous process of atresia which is ongoing physiologically, right? However, some of the pathological processes like diseases, malaria, viruses, antibodies can make it even faster and can waste the follicles. Okay. So by the time a woman gets 50, basically the ovaries have either consumed all the follicles or they have become atretic, and a woman is not really getting ovulatory cycles that time because ovulation is not happening. So ovaries are kind of getting aging, kind of. And that's how menopause happens, right? Now, since we said, if going back again to the physiology of the menstrual cycle, in the early part of the follicular phase of the menstrual cycle, the dominant hormone is what? Estrogen. And in the luteal phase of the menstrual cycle, which is the last half of the menstrual cycle, is dominant hormone is progesterone. So if someone is getting anovulatory cycles, then it means that they are not getting progesterone in their body. It's all estrogen, and then estrogen hyperplasia or estrogen building up the endometrium. Then suddenly when estrogen itself gets low, then there is either withdrawal bleeding, or when there is estrogen, then there is a threshold that after that estrogen says, I cannot grow up more endometrium than this. So this is what we call estrogen threshold, and it crosses the threshold and endometrium starts shedding off and the bleeding happens, which is apparently taken up as menstrual bleeding. So simply what I'm trying to say, that when menopause is approaching, most of the cycles are not ovulatory, and anovulatory cycles are due to the estrogen threshold bleeding, and they can be, that's why, irregular, and they can be, that's why, heavy. Why heavy? If there is progesterone, it makes, remember that again, the picture of the menstrual cycle in your memory, that when estrogen is building, the vessels are a bit wide bore and they are stem vessels. When progesterone comes, it makes a narrow, coiled vessels. So when a coiled vessel breaks, suppose from the end, the bleeding will be less because it's a narrow vessel. But if a vessel break up from the stem, which is a broader vessel, then of course there will be more bleeding. So that's why estrogen threshold bleeding, which is irregular cycle, anovulatory cycle, will give more heavy cycle rather than the progesterone based or progesterone primed up cycle. So that is about the perimenopause, that in perimenopause, the women will be getting irregular bleeding and heavy bleeding, and they will be very happy when the menopause happens. By definition, the menopause is when a woman did not get menstrual cycle for a year. So, and the mean age of menopause is up to 51, but again, can be from 45 to 55, this is a wide range. So that's why the mean has been calculated as 51. However, the most of the women gets between 49 to 52 their menopause. And again, menopause is just the absence of the periods. It doesn't really mean that everyone has to get cranky, agitated, depressed, and osteoporotic. Really, it doesn't mean that, because this is really the lifestyle. This is, that's what I said, that miskin 2 ovaries have been blamed for the whole osteoporosis. The miskin 2 ovaries have been blamed for the fracture of the femur in a woman's lifetime. The miskin 2 ovaries have been blamed for all, this euphoria. And if you go to the dose of the hormone which they were giving you, the estrogen, that was very minimal. Like if I give that minimal hormone as an HRT to any woman, it may not help, and it may help, but it may start causing the other side effects rather than doing good. It may do bad to them. So it's more again as a lifestyle thing than menopause itself. So menopause is at the minute, I think, considered as hot flushes, urinary incontinence. Cardiovascular disease is really a myth because estrogen has never been cardioprotective, but I know it was considered as being cardioprotective, but I don't think that it was. It's more with the lifestyle and mindset and diet. So if especially in our culture, it is taken that it's okay to be less active. It's okay to be obese. It's okay to be, sedentary lifestyle because you are already old. So let other people serve you. There is a difference between menopause and this kind of the lifestyle. That's what I truly believe.
Okay. So Dr. Farah, a lot of medical students or mothers might be experiencing menopause. What would be the first symptom that would really ring their bell or indicate that maybe it's menopause that is occurring?
Yeah, that's why, Shaima, when I was telling about the menopause, I focused more on the perimenopausal symptoms. You get it? So they will understand what is this. So menopause is just absence of the periods. The whole lot starts before the period stops, isn't it? So
Yeah.
you may be getting a period and your ovaries have already stopped working. Get it? So hot flushes can start even before the periods are being stopped. So that's why in the other places it is called the change of life. Maybe I'm going through the change of life. That's what the people perception is. So I think we should just look at not the period and look at the other symptoms which can be more easily treated for your parents. Like if they are getting agitated and depressed, it may not be only the periods. It may be they are going through some other problems like emptiness syndrome. Children are moving away, or they are not as busy as they were before. Retirement is one of the things. I mean, I know nowadays the children are going away for their studies, but the girls are going to get married anyway, and they are going to go and leave the house. So there's so many physiological things, as a lifestyle taking and happening. So I think the parent should be loved, and one thing, I think when as a mother now, I'm telling you, when the children are young, they are dependent on their parents. So parents are feeling responsibility for them and for doing their chores. It just keeps them busy. But when every parent wants their children to be very independent. But when they become independent, then the parents are telling, oh, I know you don't need me anymore. You see? So that kind of the feeling shouldn't be there. Parents should be given time. Parents should be given attention. And as I say, I'm not saying that osteoporosis is not a fact. I'm just trying to stop linking the osteoporosis with the menopause and stop thinking that osteoporosis is physiological, so let it happen. Osteoporosis can happen even the males. How many male patients are fall in the toilet and getting fracture of the femur? Because osteoporosis can happen to anyone. So it means that if your parents are complaining of body aches or complaining of bone age or complaining of joint pains, please take it serious. It's not like, okay, you're getting aged, that's why it is happening. So backache, that's why it is happening. It's not that's why. Just, get them be seen by the doctors, get their, Dexa scan done. So see if they are osteopenic or osteoporotic. Give them vitamin D. Are they really exposed to the day life? Now we are all thinking that we are very blessed and we are living in sunny countries, so we are fine. But we are not fine, because look at our dressing. We are fully covered when we go outside. And even if face is not covered, what we do? We don't forget to put sun lotion. So we are blocking the sun. So most of us are depriving ourselves from the day, from the sunlight or daylight. So we need vitamin D, and vitamin D alone deficiency can cause too much depression, can cause osteoporosis, and cause muscle dystrophy. So these are the things which should be taken seriously. Not taking it that it's easy, and do not put everything on the psychological and agitation or anxiety. Just please take it seriously. Look after your parents. However, the more important points is, as I said, osteoporosis. None of us want their mothers to have fractured femur in the middle of the night, because it's not just fracture that you will correct it. I know my aunt had fracture, and next morning, before we could have rescued her, she got pulmonary embolism out of this fracture and she died. So, these are, consequences can be difficult. And then cardiovascular disease are also life-threatening. So when we say that, we were thinking first that ovaries are very cardioprotective and estrogen is cardioprotective. So we started to give as an hormone replacement therapy. I haven't mentioned hormone replacement therapy until now, because when we started this hormone replacement therapy, initially we did, like evidence-based, and we did randomized control, and we chose the women, voluntary women who want. So women like me who were very motivated for their health, immediately went first of all for corona vaccination, went first of all for HRT, and the results were very good, because there were already those women who were looking after their health very seriously. So the initial study of HRT came and they said, oh my God, HRT is magic drug which is going to reverse the clock. It keeps you young, it keeps your bones strong, it is cardioprotective, because when they gave 5 years of HRT, they found no side effect and all good things. So after this study, they said that HRT is for everyone. So then they started to give it for everyone. Everyone means they started to give it all depressed women. They started to give it all obese women. They started to give it really osteoporotic women. And then they found there was no benefit. Can you believe? Rather, they found that the most of the women were dying of heart attacks. That's why when I spoke about the cardiovascular disease, I'm talking about this thing. So then they found out that actually estrogen is really a thrombotic hormone. Estrogen causes thrombosis. So estrogen was the cause of the heart attacks in the women who were given HRT. So if woman is already coping up with this, so then there is no need to give them HRT. Now another thing which is linked with HRT is the breast cancer, right? Because breast tissue, estrogen, uterine tissue are, responsive to estrogen and progesterone. However, there is some difference in the receptors. There are some selective estrogen modulator which work on breast and which work on endometrium. So simply, whenever you take estrogen, we should consider that if it has a bad effect on the breast or not. But still, like breast cancer, relationship with HRT is not that somebody has taken for a couple of months HRT and they will get breast cancer. No, it's not like that. If somebody is already low risk for breast cancer, for them, it will be like 5 years of continuous HRT will increase little chance of getting breast cancer. 10 years will increase more chance of getting breast cancer. But still, since breast cancer at its own is the first number one cancer of the women's death, So HRT does have some relationship with the breast cancer, though very little, okay? Then HRT does not have any relationship with the cervical cancer, because cervical cancer is all human papilloma virus and nothing else, right? HRT does not have any relationship with the endometrial cancer, rather it is protective for endometrial cancer, right? And same is the case for the ovaries.
So HRT, would you, right now you, like a minute ago you said it can cause blood clotting and thrombosis. So is it still recommendable?
Well, in my personal practice, I first give a trial of, the healthy lifestyle. Healthy lifestyle is, even if you prescribe HRT, it is still, like healthy lifestyle needs to be there, right?
Mm-hmm.
Two things where I prescribe HRT, okay? One is the women when they come with atrophic vaginitis, right? Because their vagina are dry, they're getting dysuria, they're getting itch, and then they're prone to get vaginal infection as well. So 6 months, 3 months of local estrogen treatment has very, very little side effect. It does not increase the thrombotic things, and it really improves their symptoms, and it gives them good vaginal skin. Because again, as I said, that there are selective, the things. So vaginal skin immediately responds to the estrogen therapy, and I don't give them progesterone then. I give them only estrogen in a very, very minimal dose, and it's mostly like either vaginal pessary or the cream, which can be applied locally. Okay. So atrophic vaginitis, yes, I gave them. And it really helps them, because when they come back in 4 weeks time, 6 weeks time, they are feeling a lot better, and even at examination, the skin has much improved. Now the other indication where I give HRT is hot flushes, because when hot flushes happen, those people who are suffering are really, they know what it is. So nothing should be taken lightly. I don't take anything lightly. I do take it seriously, and I do prescribe medications, right? So hot flushes, I give them estrogen. Again, there is a safer way of giving estrogen. You don't have to give the tablet where it goes into the system, affect their liver, and then the patch is a very good thing, because it passes the first bypass of the liver enzymes. So it is absorbed from the skin, and it fulfills the job very well. So Estradiol is a patch which can be prescribed for hot flushes, right? Okay. These are the two indications.
It's available in Pakistan.
I think it should be.
Okay. Okay. Thank you, Dr. Farah. I have some questions piled up from the session on menopause as well. So I would like to call Afifa, who is my activity coordinator, Afifa Latif from FJMU. Can you please unmute yourself and ask some questions from the audience, please?
Can't hear her, no?
Yeah, Afifa, there seems to be some kind of problem. We can't hear you clearly. Is that a fixable problem?
No, we can't.
No, it's barely audible. It's okay. I can ask Fatma to ask the questions. Fatma, can you voice the question instead?
Sure, no problem. The first question was how often should menopausal women get checkups or pelvic examinations?
Very good. I think your question before that was even more important. Remember, the first question you asked was that if a menopausal woman get a bleeding, is it a good sign, and is it okay to have the bleeding? And the answer was absolutely not. I miss sometime Pakistan. I remember a 70-year-old granny was brought by a granddaughter or daughter-in-law, and they said that suddenly our old granny is started to become young. I said, how? They said her hair, which were absolutely gray, are turning into black, and she's getting her periods. And they were so happy about it. And I said, no, she's getting cancer, which is most likely hormone producing cancer, and let's investigate her. So post-menopausal bleeding, 90%, no, I think 90% is exaggerated, but you just keep a high risk of having cancer, right? It should always be investigated. Most likely the cause would be benign, like atrophic vaginitis. Most likely cause would be a benign polyp. Polyp is just a cystic swelling which is, having fed by a large vessel, and when polyp bursts, it starts bleeding. So it's a benign thing, but it needs to be investigated. Any postmenopausal woman, or actually even perimenopausal woman who is having heavy periods, or postmenopausal women who starts getting bleeding after the bleeding has been stopped for a year, must be investigated. So what is the investigation like? Gold standard is endometrial biopsy. Either you take a PIPEL. PIPEL is a very, very tiny kind of the straw-like thing, It's even tinier than straw, which goes inside the uterus, and like a syringe action, it has a stellar in it. You pull it and it sucks some fluid or some cells from the lining of the womb, and you get your biopsy, send it to the lab. Or you can do a proper dilatation and curettage, like you dilate the cervix with the curetane, you spoon out some of the lining of the womb and send it to the lab. So this is a standard treatment of the biopsy of the lining of the womb. The other thing, I love ultrasound. So sonography will tell you exactly what is the thickness of the lining of the womb, thickness of the endometrium. So as we said, that thickness of the womb changes even in a daily basis on a menstrual cycle phase as well. So premenstrual, it is very thick. Postmenstrual, it is very thin. And postmenopausal, it is extremely thin. So say if in a premenstrual phase, it is 2 centimeter, menstrual phase, it is like 0.8 or 0.5 centimeter. In postmenopausal women, the endometrial lining should be less than 0.5 centimeters. So it's normally 0.3. So on a transvaginal scan, if the endometrial lining thickness is only 0.3, it means that this woman is not having cancer. Most likely the cause of the bleeding is atrophic vaginitis. However, I will still insist to have the biopsy. Now, having biopsy with dilatation and curettage is fine, but because, the meticulous and the gold standard will be to combine it with the hysteroscopy. Now, hysteroscopy means, as it says, hystero means womb, uterus, scopy means camera. So you scope the uterus, put a camera inside, look at the corners, look at the upper wall, down wall, and see if there is any polyp, remove it under direct VN. And if you don't see any pathology, then just cure it and take the biopsy of the lining of the womb. So hysteroscopy, dilatation, curettage is the gold standard of any postmenopausal bleeding. If you don't have an access to it, then at least do the transvaginal scan and PIPEL biopsy. And if you can't do both things, then don't just sit on the postmenopausal bleeding, do a hysterectomy. This is what we used to do in Pakistan. Just do the hysterectomy. So the hysterectomy will save them from endometrial cancer, will save them from cervical cancer. And when you are doing hysterectomy, why to keep ovaries for those postmenopausal women? So you take away the ovaries as well. But it unnecessary, we shouldn't be doing anything, really. It's not difficult to get a biopsy, okay? Now, this was the answer to your first question, okay? Now, your second question was what? Forgot.
It was how often should menopausal women get checkups or pelvic examinations?
Yes, perfect. As I told you, that women's health does not mean that when the symptom happens, you should be taking your mom or you should be taking your granny to the doctor. These are parts of the regular checkup. And if you go to, any developed countries, formularies, or, what is like, even if now you are getting these health cards in your country as well, it doesn't mean that you go to the doctor when you are sick. There are regular checkups, and this is exactly what your question is. So a postmenopausal woman should have breast examination, mammogram every 2 years if they are normal, right?
Okay.
Every 2 years mammogram if they are normal. And every 5 years pap smear if it is normal. So say if menopause happens at 50, so it means they get pap smear at the age of 50, 55, 60, 65, and then no more, right? And then, but the main thing is not the cervical cancer and breast cancer, because whenever they will cause symptom, it will be immediately caught up. Even endometrial cancer is the good one to be caught up, because it will cause bleeding and the woman will get symptom. So the thing is to get the woman before she gets the problem. So the worst or notorious cancer which comes without symptoms is actually the ovarian cancer. Because ovaries are very tiny, the minute, and the woman in her lifetime has been, accustomed or has been trained to carry a 3 kg baby inside her womb, right? So the womb, the abdomen is distensible organ, right? So she starts getting fat, or not, yeah, actually she is perceiving that she is getting fat, but her abdominal girth is getting bigger. And ovarian cancer is actually flourishing inside, and nobody comes to know until she really notices that only her tummy is getting big, and actually she is getting loss of appetite, and actually she is losing weight. And then you say, oh my God, this is ascites now already. So once ascites is there, it means that the woman is already in the 3rd stage of ovarian cancer. So the answer to this is that how frequently? Once a year for ovarian checkup. Ovarian cancer checkup is once a year. And how do you do that? It's simple. That scan is my main modality everywhere I do,
Yeah.
So do a transvaginal scan done and see what are the size of the uterus. If they are getting, in a bulkier mode, then somebody should be thinking. Or if there is any free fluid, somebody should be thinking. If you don't have scan, even a bimanual vaginal examination to see the size of the ovaries will be enough, right? However, if you want to add CA125 is the first tumor marker which gets raised. So CA125 plus TVS will give you more than reassurance that this woman does not have ovarian cancer. Okay?
Okay,
now,
thank you.
Not complete, Shaima, not complete. The most important is the Dexa scan, right? Because the women are being, the quality of the life is getting worsened by the fractures of the femur. Don't forget, the fracture of the femur in old age is a bigger problem. So Dexa scan. And do not, I think my colleague, my friend who is urogynecologist will kill me if I don't mention urinary incontinence. Now, urinary incontinence has also been considered as related to estrogen deficiency, and it's okay to have it, It's not okay to have it. Actually, urinary incontinence is very much, because as we understand that urine, the control of the urine is, through the autonomic nervous system, right? And then the anatomical thing of the urine control is through the urethra, trigone of the bladder, and those. So getting prolapse is the weakness of the muscles, we all agree. But does this weakness coming only because of the poor estrogen? It's, I think, more the lifestyle, and as a whole, the muscle weakness, not only just the trigone of the bladder. So if they continue to get a good lifestyle, especially pelvic floor exercises, and do not lift heavy weight, then they shouldn't get really urinary incontinence. Okay? But if you do get urinary incontinence, it can be treatable, Pelvic floor exercises is the first thing. Awareness and pelvic floor exercises, and then you have the options of the medicines, and you have the options of the surgical treatment for them.
Okay. All right. I think we have time just for one more question. So Fatma, if there is one question that really stands out to you, we can ask that, and before we end the session.
I still need 5 minutes from you. Did you, there was one MCQ. Yeah, I have to go through this MCQ.
Okay, sure.
So can everybody read this? That menopause symptoms only begin once periods have ceased. is diagnosed by measuring serum FSH, occurs at mean age of 45 years and may follow chemotherapy or radiation therapy. Basically, these are all style true and false. So I'll just read one time and you say true or false. So menopause, A, symptoms only begin once periods have ceased.
False.
True or false? False, yeah, because
Yeah,
symptoms may
false.
appear even before menopause or even after menopause.
Yeah.
Because menopause is 1 year after cessation of the period, isn't it? So menopause is diagnosed by measuring serum FSH, follicular stimulating hormone.
Mm-hmm.
False. False. Because any perimenopausal woman might be having a high FSH, because actually she will have high FSH before her period stop, and we'll say menopause is after 1 year of so it's false. Now, what is the range of the follicle stimulating hormone in a life cycle? As we said that we have estrogen, we have progesterone, daily variation. So what is the interpretation of the FSH? I like FSH, by the way, because it tells you many informations. In a fertility age group, or say in a childhood and adolescent, the menopause will be on a very minimal level, 1 to 2, that's it. But when they start fertility age group, then premenstrual phase or just early day 2 of the menstrual will be 3 to 5, which is normal. And when we are doing this for the purpose of infertility, if the menopause is less, if the FSH is less than 8, we say that you have very good prognosis of getting follicles, healthy follicles. If it is more than 13, 1-3, then we say that maybe ovaries are a little bit resistant to your fertility treatment. When it jumps to above 30, then it means that woman is going into the menopausal range. So above 30 is where it indicates that ovaries are a little bit failing. Normally, if you check FSH in a woman of 45 years of age, it will be like 60s, 100s, 80s, like that. Okay. So, but we are not, but still, perimenopausal. Remember what I said, above 45, perimenopausal. A woman might be having 70 FSH, 70, but you won't be telling her that, oh, you are menopausal, because she will give you a slap and she'll say, I just finished my period yesterday. You get it? So it doesn't really have a strict relationship with stopping of the period. Okay. It will eventually, but when, you don't know the answer. So menopause occurs at mean age of 45. It may occur at the age of 45, but mean age is 51, right? Menopause may follow chemotherapy or radiation therapy. Answer is yes. I say so because the statements say may, because yes, you see, it is true. So because what does chemotherapy and radiotherapy do? They just kill the cells who are actively dividing. Yeah. So in ovary, you have cells who are actively dividing, who are going to meiosis, mitosis, and these kind of the changes. So it just kills them as well. So if a young girl or anybody who wants to preserve their fertility, nowadays what you can do, take their follicles, freeze them. Okay. Yeah. Okay, good girls. Now, that's it. This is the menopause. Yeah, one more question if anybody wants.
Yes, we have a few more questions actually noted. So Fatma, can you take the stage for that?
All right. Someone had asked that their mother is going through premenopause and she's been getting ill much more frequently. Recently, she was diagnosed with gallbladder stones. Previously, there was a chocolate cyst as well. Should she be going ahead with estrogen therapy as it's getting really hard for her?
Therapy of what?
Estrogen.
Estrogen.
Estrogen therapy is not going to prevent gallstones. What is gallstone? You remember your surgical professor when he came to teach you gallstone? What did he say? You know what my professor told me when he came to teach? Me and my husband, we are still discussing it. Remember, he came and he said, in the middle of the night at 2 a.m., a woman wakes up her husband and says, look, I am 40, I am fertile, I am fat, I have 4 children, but I am going to die. because I have too much pain. And when I die, do not do second marriage. So basically, the relationship with the gallstone is F.
Yeah.
Other than Farah, it's fertile 40.
Oh.
Right? Yeah, these are the estrogen is not in the picture at all. So getting cholecystectomy is fine if they have gallstone. It's another pathology. Let them have it. HRT is not going to prevent gallstones, right?
Yeah.
A lot of people were asking about lifting heavy weights. How does that affect someone going through menopause?
No. Just consider about the, what do you call it, muscle action, force, and power into your mind rather than menopause. You might have heard that a 14-year-old girl cannot lift because she might be very weak, right? A 40-year-old who has built up her muscles and going to the gym may have lift a heavy weight. So I'm trying to say that it is not really related to the age. It is the way you have trained your muscles, right? So when you go to the gym, your trainer says, do not start with the heavy weight immediately. You have to build up and train your muscles to start with the lighter weights, right? So this is what actually our mistake is, that when we are getting older, we are, not getting as, our muscles are getting weaker. There are deficiencies. Iron deficiency is something which actually, and diabetes, these things which waste your muscles, right? So you don't have muscle tone and muscle power. So a woman who is already anemic and diabetic, you cannot expect from her to lift a heavy weight. So it is more related to the power of the muscle than a menopause. So a woman who might be menopausal but has been training her body into good shape might lift the same weight. You get my point or no? Because yesterday I was talking to a friend who is 78-year-old, climbs up your Margala hills very nicely, and I'm talking about Pakistan, goes to gym every day and lifts heavy weights as well, which I cannot do, although I am much younger to her. But I am still much better maybe to another girl who is even younger to me but hasn't trained her muscles at all.
Okay.
All right, thank you.
Thank you.
We'll just, yeah, okay.
So calcium and vitamin D is very important for your mothers, okay? That is good for the bones.
Okay. Calcium and vitamin D.
Would you say multivitamins as well? That was another question.
Multivitamin is debatable because it is also like a myth. Why? Because multivitamins are all water solubles. How many vitamins are fat soluble? How many are water soluble? Can somebody answer me that? Very good. Noor has
There's four.
First year medical
Vitamin A, E,
D,
D,
E
H.
are fat soluble. Yes. Yeah. So they are, if you take K, A, D, E, you will retain some of them in your body, but B, C are water soluble and they will be gone every day, right? So the question is that if someone is really having good diet, I don't think that they need any multivitamins, but it is a very, again, debatable how much good diet we are having and how much vitamins we are getting into it, because we don't take fresh fruits, vegetables. They are all cold storage. The vitamins are there in a very, very fresh vegetables and fruits, but when you store them in a cold thing, the vitamins are gone, right? And when you cook the vegetables, the vitamins are gone. So it means if you are not really taking fresh fruits and vegetables, you are not taking vitamins. So then you need to take them and then take them daily, because they're water soluble. Extra will be lost in the urine, right? So vitamins are good.
All right. one unrelated question that was asked is that as young girls, in your opinion, as an OB-GYN, how often should we be getting checkups at a gynecologist?
Right. Then it shouldn't be just gynae checkup. It should be the overall body checkup, right? And I think everyone should have a GP who can do your routine kind of checkups, and everyone should have an accountant and these kind of the things are like and everyone should have a lawyer. So these 2-3 hours really part and parcel of your life. You need these kind of the people. Exactly, I think annual checkup is like a routine normally. Instead of waiting and something to happen, then you go. Annual checkup is normally covered by most of the insurances, which means that your hemoglobin, your blood sugar, general kind of the, now even ultrasound scan is even available in ER in all GP practices. So that's what I would say. But again, for fertility age group, married age group, when you talk about the pap smear, it is either 3 yearly or now with HPV testing, it is 5 yearly. But for unmarried young girls, it's just, I would say that CBC electrolyte checkup should be fine with a routine ultrasound.
Okay.
When you talk about, those who are at high risk of breast cancer, the screening of the breast cancer, the most effective is actually self-breast examination, which is again not daily. Every 6 months should be fine. Okay.
Mm-hmm. Okay. Okay, thank you for addressing that, Dr. Farah. Thanks for the questions, Fatma, and all our participants who asked the questions and participated. They were very active in the WhatsApp groups as well. I would just like to remind all the participants that we do have a post-evaluation form that needs to be filled out and is shared in your WhatsApp groups. Also, there is a questionnaire about dysmenorrhea for all our female medical students to fill out if you haven't already done so. If you have already done so, it's fine. And there is a live stream as well, so which will remain on YouTube recorded. So if there's any part of today's session that you missed, you can see it on that, or if there's anyone you want to share it with, you can see it on that. Thank you so much, Dr. Farah, for joining us today and educating us about menopause and dysmenorrhea and answering a lot of our questions. So this was episode 2 of Menstrupedia, and we have 5 episodes in total. So I would just like to remind the participants, today is the 24th. We don't have anything tomorrow, but on the 25th, we have a session, episode 3, which will be with a nutritionist. So in that, we can ask her all about the foods to eat, the diet management of a lot of menstrual disorders, including menopause, including dysmenorrhea, including PCOS. And then on the 27th, we will have another session with a psychologist to answer your questions about any mood swings, anyone who might be suffering from PMDD, which is premenstrual dysmorphic disorder. So that would be a very interesting and interactive session as well. And then on the 28th, we have on Menstrual Health and Hygiene Day, we have arguably our biggest session, which will be with not saying Dr. Farah, the celebrity here, but with national women's cricket team player Kainat Imtiaz, and that will be over on Instagram, but the details will be shared in due time. So there's a lot to look forward to. There's a jam-packed week ahead of us. There's still 3 sessions left, and 3 out of 5 session attendances and pre and post evaluation forms will be required for your certificates at the end. So thank you so much. We had about 150 participants joining us today, which is a really big number. So thank you for joining. I hope you learned something. I hope it was useful for you. And thank you again for my activity coordinators, Fatma Khan and Afifa Latif, who helped me so much, and my organizing committee, all my tech people, all my people sharing the links. So thank you so much. And thank you again, Dr. Farah, for joining us on this session today. You can go ahead and leave.
I really enjoyed the session because this is what normally I actually keep the slides to keep me on the track because I know I'm very easily detracked and I'm distracted and I talk a huge diverse things. But this was, like a very much general talk, and I hope that you have we had a very light, good mood, discussion. So I hope that it was fruitful and successful for all of you. Thank you.
Yeah, thank you. You guys can go ahead and leave the session. If there's any questions that weren't answered, you can drop them in the WhatsApp chats and we can hope to get them answered later for you. So thank you so much and see you on the 26th for the session with a nutritionist. Thank you. Allah Hafiz. Bye. Have a good day, guys.
Thank you. Allah Hafiz. Allah Hafiz.